Good morning, everybody, and you're very welcome to Research Bites of the Institute of Food and Health in the 2021 series. So this morning, I'm delighted to welcome Sharleen O'Reilly. So Sharleen is Assistant Professor in the School of Agriculture and Food Science, and she's a Coro registered dietitian. And in 2019, Sharleen was awarded the Irish Nutrition and Dietetic Institute Research Dietitian of the Year. So she's a graduate from Trinity College Dublin, both from her undergraduate degree in Human Nutrition and Dietetics and also for her PhD. And her research lies in research translation, and particularly how chronic disease prevention and management can be better implemented in the real world. And this morning, she's going to talk to us about the health of women and infants. So over to you, Sharleen, and thanks again for joining us to do this morning.
Thanks, Dolores. Well, I'm delighted to be here this morning, even though it's a bit cold around the country. So as Dolores said, the title of my talk is going to be Best Beginnings, Delivering Better Health in Women and Infants. And I suppose Dolores gave a snapshot there, but as she mentioned, I started life, inverted commas, in Dublin and did my undergraduate in Human Nutrition and Dietetics, and then went on to do a PhD after working as a dietitian in the UK for a while. I then took the very long flight over to Australia, where I was based for 12 years, predominantly at Deakin University. And while I was there, I moved my focus from what was my PhD area of research, which was around colorectal cancer prevention, into a more preventative space that was focused around cardiometabolic health, so diabetes prevention and also cardiovascular disease prevention, with a particular focus on gestational diabetes, which I'm going to talk to for the rest of this talk. So after 12 years, I had a bit of grow to come back to Ireland, and I came back to UCD and obviously have been here since. So I'll get started now on kind of the key questions that I was asked to kind of look into for the talk. So what are the main challenges that my research focus is taking care of, I suppose? And I was fortunate in Australia to be awarded 2 different fellowships in the area of implementation science, or translating research into practice. And you can see over on the right that this image to me speaks volumes to the space that I try and work in. So it's from that bench to bedside translation. And as you can see, it's been coined as the Valley of Death. And it's in essence of quite a treacherous path that you have to traverse from discovering something to making it work in the real world. And we know from the literature that this transition period takes about 17 years. So when you think about it, there's quite a lag time between those 2 things. And when we look to doing implementation science, we're trying to make the crossing a little bit more secure and hopefully increase the acceleration in terms of time that we can get something happening in practice. So from research practices, you have varying degrees of quality, and most people would be well aware of this hierarchy of evidence, with your randomized control trials sitting at the top of that evidence. And then when you bring together randomized control evidence as well as others in a systematic review process, and do potentially a meta-analysis of that, you have a reasonable degree of assurance that what that data is telling you is that X effect will happen potentially in a Y setting. And then normally what we do in that area is we would put together clinical guidelines. And so generally clinical guidelines sit above that hierarchy of evidence. So this is the how-to guide of how to actually get that evidence into practice. However, the challenge then lies in how do you change people's behavior to allow them to do those clinical guidelines in practice. And so implementation science really focuses about a central question: who needs to do what differently and when? And that's really that kind of messy space that I do my research in. So another way of looking at implementation research or implementation science is thinking about bringing evidence from proof of concept. So does it work? to proof of implementation, can it work, right the way through to informing scale up, which is, can we make it work in the real world? And so it's that transition of going from quite a controlled internal environment where you've got strong internal validity of, say, an RCT, through to these more scale-up type studies where the external validity is actually what you're trying to measure. So the messy stuff that happens in and around delivering care is actually what's going to impact the ability to deliver your intervention. And so you need to have more measurement of that external environment as opposed to the internal environment, because you already know that it works. So as I said, gestational diabetes is going to be my focus. And I go back to this picture over and over again to remind myself of what the real implication of gestational diabetes can be for someone if it's not managed. So in this case, as you can see, there's quite a sizable difference in terms of a neonate, a newborn that's had gestational diabetes. And that baby is a very clear example of one that is not going to be able to deliver in a normal delivery. So there's going to be cesarean section, there's going to be a whole range of interventions potentially that mom is going to have that mean that there's a concern for her health at birth and also a concern for the baby's health when it's born. So birth complications are really common with gestational diabetes, and actually gestational diabetes in itself is the most common complication that a mum can have in pregnancy. And in Ireland, we have quite a high rate of gestational diabetes, and we have 1 in 8 women experiencing gestational diabetes. So it's common, it's a problem, it's a concern, it's actually a cost for both the health of the mum and the health service. So it's something that is a real implication for the health of the mum. But it's not only a complication at the time of birth, it's something that we need to consider going forward, because we know that 1 in 2 of those women that experience gestational diabetes are at risk of developing type 2 diabetes. And so the key thing to think about is that if at a population level you were to look at it, diabetes in pregnancy, so gestational diabetes, is the single strongest predictor that we have at a population level of identifying women who are likely to go on to get type 2 diabetes. And those women are going to get it way earlier than somebody who is at an older spectrum, where we normally consider people getting type 2 diabetes in their 50s and 60s. These women are potentially getting diabetes type 2 when they're 35 or 40. So the cost to the health service and to the broader society is actually much greater. We also know that diabetes in itself is the single biggest health cost to the EU health service. So it has quite far-reaching complications to a lot of different parts of life if you have more gestational diabetes happening. And that's actually what we're seeing, because we know that weight and weight status is a strong predictor of getting gestational diabetes. The rising weight of our population is also translating to the rising weight of mums who are achieving a pregnancy. So we now know in Ireland that basically 1 in 2 mums are entering into pregnancy with a BMI of greater than 25. So that's a real concern, that our rates of gestational diabetes are going to keep climbing within our population as that weight keeps rising. However, it's not all doom and gloom. There is a treatment, and it's an effective treatment, and it's lifestyle modification is what we sort of term our medication to be. And obviously that's where, as a dietitian, my interest came into very much into focus. But we know that if you give a diabetes prevention program focused around healthy eating and physical activity to adults, you will get a 60% reduction in risk at 1 year. And you'll also get a sustainment of that risk reduction. So at 10 years out, you still have over a third at a reduced risk. So it does work if you can give it to people. And that's kind of where my interests in implementation come into play. We know from the really large diabetes prevention studies in both Finland and the US, and this was what their prescription was. So it was around weight loss and physical activity in the US. They didn't really mind what you did with your diet as long as you achieved the weight loss. But in the Finnish one, they had quite prescriptive targets. So they had 5 goals, and they knew from their data that if you achieved all 5 goals, there was a linear relationship with diabetes prevention. So the individuals who achieved all 5 goals actually never went on to get diabetes. So it's quite strong evidence that says that this is a really effective treatment. However, when you look to mums who are way younger than what were the 60-year-olds that took part in these diabetes prevention studies, they've a lot going on externally to that diabetes prevention program that needs to be accounted for. So in essence, I love the phrase that they used in Australia to say it's the same, but different. And it kind of comes from Asian cultures where they would say, you know, it's subtly different, but you do need to understand the differences. So for diabetes prevention in the postpartum period, there's some really strong evidence coming out of both systematic review as well as qualitative systematic reviews that talk to what are the differences that you need to consider. So you can see here that any of the ones that are ticks are enablers, and any of the ones that are X's are barriers to engaging in a diabetes prevention program. So there's a lot going on that actually needs to be tweaked or tailored to mums to enable them to take part and to receive the treatment, if you want to say, in a way that's acceptable to them and effective. So this kind of leads me to where my research has worked. And so I've worked in maternal and child health now for quite a period of time, and I'm working across the spectrum, I suppose, of that, you know, can it work, does it work, and can we make it work in the real world? But I'm going to focus in on the last one there on the right, which is Bump2Baby Me, and how we got together our evidence to support this study. So while I was in Australia, I was one of the leads on a randomized controlled trial of a system level intervention, and it was called MAGDA, or Mothers After Gestational Diabetes in Australia. So MAGDA is quite a common name in Australia, so we went with that for another reason, as well as the very cute, obviously, kangaroo giving you that whole Australia vibe. But the intervention itself was over the course of a year, and we took mums that were within their first year postpartum, and they were allocated to one of 2 arms. The first arm being the intervention one, where we had 1 individual session and then 5 follow-up group sessions over a 3-month period, and then 2 top-up telephone coaching sessions. And what we saw was a little bit disappointing in terms of the trial outcomes. So typically with diabetes prevention studies, you expect to see roughly a 2 kilogram difference between groups. And we only saw 1 kilogram. And now, while that was meaningful at a public health level, it wasn't the extent that we wanted to see. We then went and looked at the implementation data that we collected as part of the study, and we could see that while we'd retained the women sufficiently, we actually could see that the intervention engagement, so I use the analogy of a pharmaceutical trial, you know, you've got to take your tablet for it to work. So if you don't take the tablet, it isn't going to work no matter what you do. So what we could see is that a lot of the women did not attend all of the group sessions, and that there were a reasonable proportion who had only 1 group session attendance. So if that's to be borne in mind, that tells you that there's something wrong with the way that you're implementing the evidence. So we then did a subsequent study, which is called TeleMAGDA, which was translating the intervention component into a way that could be delivered over the phone. So we had a health coach, we translated all of the sessions into individual sessions, and we delivered it over the phone. We then saw that we could get the effect size that we were expecting to see, and that we had 100% retention, and we also had 82% of the mums that took part getting all of the sessions. So in terms of the delivery vehicle, it appeared to be a better fit for what this population actually needed. And we did a bit of patient involvement work where we co-designed up the translation of the manual that was delivered in TeleMAGDA into an app, because mums had said in their feedback to the study, well, listen, the manual was great, but it wasn't any good when I was late at night and I was trying to actually do something while not waking up anyone else. So they wanted something on their phone. So we then tested and developed up an app that in essence supported the delivery of the health coaching. So around similar times, we did a whole barrage of systematic reviews to really understand what the gaps were in that delivery mechanism. And the first one was focused around an implementation framework, which is called PIPE. And that is participation, implementation, penetration, and effectiveness. And what these are basically, if you think about organizing a dinner party, you've got to invite people, they've got to turn up. Do they get the menu that they expected? And then also, were they happy with the meal that they received? So in essence, each of these tell you a little bit about your intervention. Sorry, that's my voice. Your intervention and whether or not it actually had the key ingredients that you need to have success. So penetration, we know from looking at over 49 studies in the systematic review that I was the lead on, that only one reported the penetration rate, should I say, and that was really low. That was 2.5% of the population. So of the eligible women with gestational diabetes that you're trying to get into your interventions, they only had 2.5% engaging in their RCT. In terms of implementation, only 50% of the studies reported adequate information to be able to calculate whether or not somebody got the intervention as described. And in those that described it, they only got a low score in terms of the fidelity, the way with which they had delivered it. When we looked at the participation, so this is, do women stick with an intervention? This was really variable. If somebody took part in an intervention that was aligned with what was being done in usual care, there was good participation. But where something was being perceived as, being delivered as an RCT that sat outside usual care, then the actual participation rate tended to be lower. And then in terms of effectiveness, we could see that generally across studies, they were achieving that roughly 2 kilogram weight loss that we were expecting to see. In a separate RCT, we then had, not RCT, do you hear me, a systematic review. We looked to see, did it make a difference who was delivering our tablet? So we explored interventions that were delivered by healthcare professionals versus those that were delivered by peers or other community representatives. And what we could see is that there was a significant difference in the delivery rate and success rate in terms of weight loss when the RCT was delivered by a healthcare professional. So actually who delivered the study was important. We also found that what we know is to be true, but it just reinforced the fact that diet and physical activity together were more effective than physical activity interventions alone. And that surprisingly, the way with which an intervention was delivered, so the duration of the sessions that people were having, the number of sessions that people were having, and also the setting being either individual or group, didn't seem to have a significant impact on the amount of weight loss. So that gave us a good barometer around designing an intervention that could be delivered with relatively low intensity and frequency, could be delivered individually, and gave us some cues around the implementation of what we should do. Another step that we took in systematic reviews was also identifying the behaviour change strategies that needed to be incorporated for it to be effective. So when you think about lifestyle modification, it's around healthy eating and physical activity, but these are behaviours that people need to change. And so you can't just tell them go and do something and they go and do it. You have to support them to change their behaviours. So you can see here the list of things that were identified as being significantly associated with decreasing energy intake. And obviously, we know that if we can modify energy intake, we should in turn see a corresponding reduction in weight loss at the outcome. So those were all behaviour change strategies that we incorporated into the Bump2Baby Me. And then finally, recently, we were looking at how acceptable health interventions were, and through qualitative systematic review in mums with gestational diabetes, the factors that we could see in the behaviour change strategies also were mimicked within the qualitative factors that mums really wanted in their health strategy. So all of this information, alongside a lot of other systematic review information and other randomized controlled trials in this population group, came together into the Bump2Baby Me study, which started last year. Now, UCD is the lead on this, and then the National Maternity Hospital are our clinical site. We have a clinical site in Spain, in Granada, in Melbourne at Monash University, and then also in Bristol in the UK. We have additional partners in Denmark around the delivery of the app for the intervention, as well as a dissemination partner in the UK, and Deakin as a clinical sort of assist partner in Australia. So we're spread out all over the place. And what the intervention is in essence, we have an implementation component in terms of the way we're identifying mums. So we've implemented a clinical risk screening tool in each of the 4 sites, where we will be identifying women using a validated screening tool that's put into usual care. So all mums that come in at about 10 to 14 weeks pregnant will be screened for their risk using the tool. And if they get a score of greater than 3, they will be eligible to take part. And if they take part, then they will go into the usual care arm, or the usual care plus the health coaching app, which is Bump2Baby Me. And within the app, they have access to synchronous, so real-time interactions with a personal health coach, and also asynchronous contact with that coach. So that coach will work with the mums for the 18 months that they're going to be in the intervention. So it's quite a long intervention. And that will cover pregnancy and the first year postpartum. At the end of the first year postpartum, we will do obviously assessment of clinical change markers in both the mum and the baby. But we also, in terms of the implementation component, we have a whole series of data collection that we're doing at the start, through the study, and at the end that will hopefully influence the implementation into the future. So it's relatively easy to say who's going to be impacted by the research that I do. My end goal is that women and their families benefit from it, but obviously healthcare professionals, in being able to deliver care at the guideline level more effectively and more efficiently within the systems, and then having to influence the decision makers and the policy makers so that they can actually support the delivery of the care that we think is the best and most effective one for mums in this group. How is my research funded? Well, I've been fortunate to find money around the place. In Canada, when I first came over from Australia, I worked with colleagues in Denmark and Canada to get funding about a core outcome set. So that's about identifying what are the key outcomes to be measured in intervention studies in the postpartum period for women who've had gestational diabetes. And that has resulted in a good few publications and nice networks being built up from UCD with the other organisations. I last year was successful as the lead at UCD in a HRB Collaborative Doctoral Award, and this is working in chronic disease prevention, and it's been brilliant. I've had a PhD student start, Pauline Dunn, and she's working in the area of doing postpartum gestational diabetes prevention in primary care. So we're going to be working with CHOs here in Ireland over the next few years to try and get something up and running here in Ireland. The Horizon project obviously is a big project. It was co-funded with the NHMRC in Australia, which is the National Health and Medical Research Council, and that's going to run for 5 years. And then I've been involved as a lead in a Department of Health, so that's the whole of Australia, messaging application piece, where we're actually trying to improve the message that goes out to mums for highlighting their risk and getting them to engage in diabetes prevention services. And then finally, most recently, I'm an investigator on the development of the primary care intervention that Pauline's working on, but doing it at quite a large scale throughout 2 states in Australia. So we're going to be working with a whole variety of GPs and practice nurses to deliver care at a kind of micro level within practices. So finally, what are the wider impacts of my research? Well, Bump2Baby Me, we have 4 key exploitation outcomes, and they're going to be having the app and the health coach training embedded in a way that we can actually give and deliver to other health services. There will be an accompanying implementation toolkit that comes out of that, and that's about supporting the delivery of things that sites need to do to be able to deliver the health coaching and the Bump2Baby and Me effectively within their care. There'll be an economic model for both pregnancy and the postpartum piece, as well as the policy options for the variety of countries that we're doing the intervention in. And then finally, I'd like to close by saying, for me, my end game is that we're providing the right care for the right person at the right time. So I'm involved in trying to shape the model of care here in Ireland at the moment for women with diabetes and pregnancy. So we need to have appropriate guidelines. And then obviously we'd like to have an app out at the end of it that'll be Bump2Baby and Me. But this is a bit of a plug for the holistic app that was launched last week, which is healthy eating recipes for mums in pregnancy. That is evidence-based, that is, backed up by the guidelines in terms of what we're trying to get women to achieve in pregnancy. So that's kind of where I'd like to be at the end of this piece of work. Thank you.